Good morning, respected Emerita Chairperson Sir, senior faculty members, colleagues and dear students. Today's CCR will be presented by Dr. Rolika Bansal, who is a specialist in ocular oncology and oculoplasty, and she is also a specialist in treating retinoblastoma, orbital tumors, thyroid eye diseases, lid and ocular surface tumors, and many other diseases related to orbit. She accomplished her fellowship in ocular oncology and oculoplasty under Dr. Santosh Honavar, which is internationally recognized faculty, and also done 2 more fellowships from USA. She is also member Scientific Committee All India Ophthalmic Society, executive member of Jaipur Ophthalmic Society, and many other societies too. Also recently elected as Secretary of Young Ophthalmic Society of India. She is involved in many PG teaching programs at national and international levels. She presented papers, publications in national and international stages. I wish her bright future and hope she will continue her work with same enthusiasm and lead the Department of Ocular Oncology and Oculoplasty to the highest standards. In very short span of time, in our hospital, she done many complicated and challenging cases. One of them she will be present today here in front of us. Thank you.
Thank you so much, sir, for the kind introduction, and thank you everyone for having me over, and thank you for coming for the morning lecture. So I'll be talking about Exenterate or Conserve, and before we go further, I would like to thank every single department who has been responsible for making this happen, and I can assure you that it would have not happened if it was not for the blessings of every department. So thank you everyone. So before we go further, I would like to introduce you to a case, and that is a 72-year-old female who presented to us with a conjunctival growth in the right eye, which has increased over 3 months. This happens to be our chief complaint and the history. So as such, she did not have any treatment. She has not gone to any other doctor. She came to us right away in, as the first presentation. She did not have any history of vision loss per se, and she did not have bleeding from the eye, or pain on the eye movements, or double vision, or itching or redness around the eye. She also did not have any history of fever, discomfort, pain, abdominal pain, recent breathing difficulties, back or joint pain or stiffness, any significant weight loss. However, she was not very heavy, but in case she did not have a significant recent weight loss, or any history of trauma or headache. Then she also gave us past history, that is, in the left eye she has had enophthalmos, or the reduction of the size of the globe since childhood. She had an infection, the details of which are unknown, but because of that she had phthisis bulbi on presentation. And she also gave history that right eye cataract surgery has been done in 2006, which kind of is an advantage to us, and I'll explain how. And she also gave personal history that she had had tuberculosis in 2002. She is an asthmatic and hypertensive, but not on any active treatment. She also belonged to a post-socioeconomic status we had to keep in mind, and I highlighted that she did not have any HPV immunization, and I'll come to that, why am I addressing it. So to accept a personal history, no alcohol intake or tobacco chewer, normal sleep cycle, and essentially everything was normal, and she did not have any history of any significant family history as well. General physical examination was essentially normal, but she did have a lower, the weight was actually 52, and systemic examination was overall normal. It was addressed by every department. So when we had her at presentation, we did not have actually one problem, we had many. And can I request any of the residents to help me out with it? Maybe Saloni can help, that what exactly can you see or point out over here as the problems in this patient? Anything that you can see and visualize?
Ma'am, she has an overgrowth in her right eye and a physical eye in the left.
And that's all you would like to say? Anything else is abnormal? One more thing.
I'm not sure, but I think that's a fistula in the right eye.
In the left eye, you mean? In the left eye, you also notice a small bump right there, and it was an elevation, which kind of increased our problems and not really resolved it. Why? Because at this presentation, she technically had a nasolacrimal duct obstruction as well, which is a site of infection for us. So we cannot really operate for the right eye even though we want to. So what did we do? We kept her on interferon for the right eye to make sure that we are not really aggravating the size of the lesion, and at the same time we proceeded with dacrocystectomy for the left eye. I could have done dacrocystorhinostomy, which is like making just a hole, but I actually had to remove the sac because there's no point of keeping the sac or a site of infection. So, sorry, sir? Interferon, topical interferon, sir. Right. So this is how the patient presented. The mass was actually the same size. It kind of looks bigger, but it was actually the same. In fact, the periphery had started going down because of the interferon component. And on the left side, you can see that the nasolacrimal duct obstruction has been taken care of. This was an early intervention. Usually we take 6 weeks before we can operate further. But since the lesion in the right eye is more important, so we kept a gap of only 4 weeks so that we can proceed further. Now at this time you can see that this is how the patient presented. Can anybody, maybe Dr. Lokesh can help me, what exactly are the findings as you can see over here? So this is a video of how the patient presented. If you can help me understand the findings of this lesion.
So we see a fleshy mass, fleshy growth, probably arising from the bulbar conjunctiva, and it seems to be pedunculated probably, and it's encroaching on the cornea, covering almost 6 clock-hertz roughly.
Right. So I agree with you. So this is a basically large elevated fleshy surface lesion, and it has limbal involvement. That means it is from 2 o'clock to 7 o'clock. It also has a corneal overlap of 3 millimeters from 2 o'clock to 7 o'clock. And also it has intrinsic vascularity in a prominent feeder vessel which is seen inferiorly, and we had phoneal extension inferiorly, and we had extension onto the medial canthus as well. This is how the patient presented to us. Now we have differential diagnosis in our mind. We thought of ocular surface squamous neoplasia, conjunctival lymphoma, conjunctival amyloidosis, conjunctival papilloma, and even a pyogenic granuloma. And keeping all these differentials in mind, we had to rule out. The whole concept is to eliminate one at a time. So I don't think it's a pyogenic granuloma because there was no history of bleeding from the eye, because usually pyogenic granulomas have a tendency to bleed on touch. Then we proceeded with elimination of amyloidosis because of the color of the lesion. It is more of an orangish hue, which was not there in our patient. And of course we also eliminate, now this is what we keep in mind. Now going forward for these lesions, we have to do something called as anterior segment OCT, that is optical coherence tomography, and an ultrasound usually in these lesions to understand whether there is a scleral invasion or not and how deep the lesion is. But in our case, we cannot really necessarily perform these two because the lesion is huge. So when we do an ultrasound or UBM, we won't be able to put the UBM cup on the surface, and we cannot do an OSOCT because it's so large that it will give a back shadow. But we have to proceed with MRI. Now before I go for MRI, I request our very capable Dr. Arushi Agarwal to please explain the MRI findings.
Good morning, respected faculty members. This is a T1 weighted post-contrast axial image of the orbit showing a well-defined lobulated soft tissue mass in the right eye along the anteromedial aspect, predominantly in preseptal region, showing diffuse enhancement. It measures approximately 2 centimeter in maximum diameter. There is also adjacent post-contrast enhancement of the sclera, suggesting involvement of the limbus and sclera. The normal fat planes between the medial rectus muscle and the lesion are lost as well, with possible early infiltration of the medial rectus. However, no obvious thickening of the medial rectus tendon is seen. The left globe as well appears mildly shrunken, which points to likely possibility of phthisis bulbi. This is a T2 weighted coronal image showing a hyperintense mass located inferior-medially with adjacent scleral thickening extending till the medial canthus and abutting the inferior rectus muscle. This is a T1 post-contrast sagittal image showing diffuse enhancement of the mass arising from the inferior medial palpebral conjunctiva of the right eye. The lesion is seen projecting into the inferior conjunctival fornix with no retrobulbar or optic nerve involvement. All these findings suggest a neoplastic etiology. Thank you.
So as Dr. Arshi has very nicely explained about the MRI findings, we find MRI as a very important part of our planning. Why? Because not just because we need to know what type of lesion it is, but it is important for us to understand the extent of the lesion, the anterior extent, the posterior extent, whether there is scleral invasion or not, whether we are able to resect it or not, whether there is any muscle involvement or not. In fact, I often have conversations with the radio diagnosis team when I call them up and I ask them that how many of the muscle is involved, what are we exactly looking at, and these are important pointers when we go forward. So at this stage, we had two options, and that is we were left with ocular surface squamous neoplasia and conjunctival lymphoma, because the concept of papilloma has already been ruled out, as because Dr. Agarwal over here mentioned that it is a neoplastic etiology. When we are looking at these two options, we must remember lymphoma is often and more often bilateral. So over here in this case, we did not have a bilateral presentation, so we are happy to rule it out. Now, if I have to quote the entire diagnosis in one shot at this point, it would be that it is an right eye ocular surface squamous neoplasia, left eye phthisis bulbi, secondary to infection, and also left eye nasolacrimal duct obstruction, which is status post dacrocystectomy. So keeping these things in mind, we went ahead. But before I go forward, let me explain a little bit to you about OSSN. OSSN is either a pre-malignant or malignant epithelial tumors of conjunctiva. Very often they are pre-malignant and they present as dysplasia, carcinoma in situ, and they range all the way to invasive squamous cell carcinoma. And the diagnosis of which is only possible in a combination of three, that is clinical, radiological and histopathological confirmation. Without that, we can never tell whether it's an invasive for sure or not. So again, superficial lesions can be treated with topical treatment or excision. It is very easy. We eliminate that and we don't need to give further chemotherapy. We don't need to give further immunotherapy or radiation if it's a superficial lesion without any invasion. But if we have invasion, that is deeper lesions with a corneal stromal invasion, we need to do something called as primary or secondary plaque brachytherapy. Now, I will introduce you the concept of plaque brachytherapy very soon. So when we have had these cases in the past, when a patient presents with such a huge lesion, in the past the only options that were there were enucleation or exenteration. I guess majority of the oncology team here would agree that these were the options which were important for life salvage because we couldn't have compromised on the same. And the other option now, that is more conservative approaches, are we do a precise primary surgical excision followed along with cryotherapy, along with adjuvant plaque brachytherapy. This is a combination that we currently prefer. We also have the options of genetics guided targeted therapy which can be utilized. However, in our country, it is pretty much difficult for us to put the patients on immunotherapy because of the cost issues. But yes, we have seen cases where cemiplimab has worked beautifully on these cases of ocular surface lesions. Another thing that we should keep in mind is sentinel lymph node biopsy. I would have loved it if the patient was interested in sentinel lymph node biopsy before the surgery, but it has two problems. One, it hinders with the plaque brachytherapy component right there, like if we do it intraoperatively. And the second thing was cost, which patient was not comfortable with. So this is how we proceeded with the excision. This is just a glimpse of how large the lesion is. The entire excision itself took 3 hours, where we had to go around the surface, making sure that the surface is absolutely clean and clear. And you can see the size of the lesion is huge, way more than the estimated MRI size and way more than estimated clinical size. Now, when we go further, we have to understand histopathology plays a very important role. As you can see over here, the base invasion was confirmed. When the histopathology was sent, we received 2 comments. One comment is that the invasive component is seen extending to the base in the medial 1/3 of the biopsied tissue. That means that one component of our surgery was very important, and that is plaque brachytherapy radiation, which I'll come to. The second component was a superior margin was involved by tumor, which was taken care of by cryotherapy as well. So Before we go further, this is a variety of lesions which we see, and I know that the audience is not really aware of the concept of plaque brachytherapy, and I'll be happy to introduce it to all because it's something important which we can actually utilize to salvage several diseases. So as you can see over here, the evolution of plaque has actually occurred over the last century. All the way where radon was the first nucleotide used for plaque brachytherapy, we have gone to the level of iodine. Iodine is more surface toxic and more retinotoxic. So again, the concept came in of ruthenium, and how ruthenium is currently being used as a landmark. So ruthenium happens to be a beta emitter. We also have photon emitters. I would actually say that iodine, palladium and cesium have done a very good job as well, and the very fact that cesium has a short half-life, it actually becomes a good utility as well. But however, we have picked ruthenium, which is a beta emitter. So it has a longer half-life than the others. It is a beta emitter, so it's not very toxic to the adjacent structures, and it has reduced dose delivery to the normal adjacent structures. When we are giving radiation, we have to also think about the surface in terms of cornea. We have to think about the lens because we can have cataract in those patients. We have to think about the muscles because we don't have to cause fibrosis to the adjacent structures. And of course, we have to think about the retina because we'll end up having retinopathy in these patients. And of course, lesser radiation-induced side effects with ruthenium. I have worked with iodine and ruthenium both, and I have observed that ruthenium has a better uptake, a better tumor uptake and lesser side effects. That's why it is considered a softer, and we prefer that. So the lesions that we have been able to treat with that would be ocular surface squamous neoplasia, as we can see here. These are pictures from where I've worked earlier, and this lesion, as you can see, is very nice and fleshy with the prominent feeder vessel. And another lesion that we have covered is conjunctival melanoma because it's very helpful. Yeah, okay, thank you. So conjunctival melanoma. We also have uveal melanoma, as you can see in this patient, where there is a hyphema settled in, and we have a small brown lesion on the side. This is an iris uveal melanoma, which can also be treated very well. And this is a choroidal melanoma, which was earlier enucleated because of the size of the lesion and because people did not know that even this can be salvaged. And this is a choroidal hemangioma, which is not a malignant lesion. It's a benign lesion, but because it gives out water in the form of subretinal fluid, therefore it is important to identify these lesions and treat them in time. And of course, we have it in retinoblastoma as well. In cases with retinoblastoma, we actually consider this as a last salvage methodology because of the radiation component and because we give it to the children, but it is considered very efficient. So, in the past, this is the plaque that was used, which is a BBIG plaque. So, this is actually a silver-plated ruthenium. So, ruthenium is sandwiched between silver, and that is how the plaque is made, which is actually of very small size. It is 20 by 20 mm. So you can imagine how small this is. It's looking pretty big on the screen. But this is a plaque which was being made in Germany by BBIG, and it used to be very expensive for us to get it over here. So the high cost and import duties made it extremely impossible for people to have it over. So the high cost and import duties made sure that there are limited centers for plaque. Earlier we had only 2 or 3 centers all over India which could afford to get the ruthenium plaque. Sorry, sir? The cost earlier, it used to be approximately 6 to 8 lakhs to just get the plaque. And there was restricted availability, but at the same time, to get the licensing for the same used to be added costing. So it used to cost nearly 25 lakhs for anybody to set up that center, which is a major issue. And again, we had restricted availability and we had affordability issues, because when we have it a high cost as for us, we won't be able to charge the patient less as well. But we came up with a Make in India initiative, and this plaque was reinvented in India under the PM initiative, where India went indigenous, and we came up with the plaque that is called the BARC plaque with the Bhabha Atomic Research Center, in which there was low cost and no import duties. So this actually is a plaque which is made from the radioactive waste. As you can see over here, this is a site plan of a kalpakkam, there's a center in Chennai, which is a waste center in Kalpakkam, from which the ruthenium is extracted out of the waste, and that is how it is implanted on the plaque. As you can see, this is being taken out and electroplated onto the plaque, and that is how we make the Indian plaque. And the cost actually goes down by 95%, which is a significant drop. And we have been very lucky that our center and Mahatma Gandhi has landed up supporting it and appreciating this initiative, and we were the first to do it in Rajasthan, and we're able to do it. We're out of the 10 centers in India who do plaque brachytherapy. So I'm extremely grateful for that. And we also did, thank you, and I think the courtesy for that goes to a lot of people and not just one person. It's a whole team involved, and I will address them in one of the slides, which is very important. And when we did a comparative analysis, but before we come up with accepting a new plaque, we have to do an analysis. So we compared the imported plaque and we compared the Indian plaque, and we saw whether we actually are getting the correct analysis or not. We actually got the similar results in ocular surface lesions and intraocular tumors. This is one of my papers which is under publication already, and in which we have seen that we got 100% live salvage, we got nearly 100% eye salvage in ocular surface lesions, around 96 to 81% in intraocular tumors, and this is a follow-up of nearly 5 years, but we are going on for the same. So primary plaque brachytherapy is when, how in this patient, for example, I anticipated there was invasion which was evident on MRI. It was already shown that medial rectus, as Dr. Arashi mentioned, that medial rectus could be involved, inferior rectus could be involved, the plane was disrupted. So MRI was helping us identify that there is a scleral invasion already. So primary plaque brachytherapy is when we do plaque brachytherapy in the same sitting as the excision, because we have already adopted that we will require it. So we do a clinical examination, we have imaging supporting it, and we proceed with plaque brachytherapy. Secondary plaque brachytherapy is when we are not sure whether there is invasion or not, because MRI, ASOCT and UBM do not give us information about invasion. But we send it for histopathology, and histopathology confirms that base is involved. If we get such an information, then we must proceed with plaque brachytherapy. And how we do that? We keep a gap of 6 weeks, and after 6 weeks we go in again and we radiate the surface so that the patient is taken care of. Because we don't want any sort of recurrence of these lesions, because high rate of local tumor recurrence is indicating a high rate of possibility of metastasis. Now before we go further, whenever we receive a patient, there are a lot of things involved. We do a meticulous clinical diagnosis, we analyze the tumor dimensions, we make sure that the size is rightly identified, because we have to also think about which plaque we use. Then we do documentation. Most important is picture. We have to take good pictures because we need to show it to the patient of how it has improved. And the next part comes is dosimetry planning. Now dosimetry planning as such involves a lot of people, and we have been able to do it only and only because we have a very good department of radiation oncology, and we also received extended support from the Department of Nuclear Medicine. And I will just request Ms. Pratibha Singh, who is the Radiation Safety Officer from the Department of Radiation Oncology, who will brief us about how exactly do we plan when we receive information from the ocular oncologist.
Thank you, Dr. Rolika, and a very good morning to everyone. So once we receive the dose information from radiation oncologist and ocular oncologist, we plan the treatment with the help of plaque simulator. So it's going on. So this plaque simulator gives us the dose rate for a particular date, and based on those dose rate, we. Okay. So in the first picture, you can see we have a dose isodose, which comes up like. Here we have given 6,000 centigrade dose to the apex, and we have seen that nearby of the tissues are not getting any much dose. Previously she has mentioned that the patient has already received the lens surgery, so the nearby tissues are of no worries. We don't have to worry about the nearby tissues. So for this, there are two types of plaques we can use. One is notch plaque, one is round plaque. and we have given the 6000 centigrade apex dose with at the 2 mm depth, and our treatment dose comes up with 16 hours 57 minutes, which is like 353.76 centigrade per hour.
Thank you so much. And I must appreciate that Miss Pratibha Singh over here is our, she's a very important part, because she lands up making sure that we give the correct dosage for the surface. Because if we give a higher dosage to the surface, we might cause scleral thinning as well. So her dose calculation actually is extremely important. As she mentioned that we have a duration, 16 hours and 57 minutes. What does this duration refer to? It means that when we do a surgical excision and we place the plaque onto the surface, we have to leave it for 16 hours and 57 minutes. And for those, it's literally like as if it's a timed event. And for that duration, sometimes it even comes out to be 3 days and 4 days. For that duration, the patient is required to stay with us in the hospital, in a facility. They're supposed to be in their isolated room as per the protocol, and they cannot leave the facility. So we make sure that we counsel our patients that this is going to be a necessity, and it's a statement which is required by the Government of India. So again,
the
yes,
2
sir.
millimeter depth, will that cover the possible rectus involvement, or will it not cover?
Right, sir. So very good question actually. So when we do a complete excision of the tumor, we analyze. So in this case, the patient, as Dr. Arushi had mentioned, that medial rectus was possibly involved and inferior rectus was possibly involved. When I did the resection, I could see that medial rectus is not really invaded. It was superficially sitting on it. And inferior rectus also was partly involved, and I had to shave off the part where the inferior rectus was involved. What I have done is, when I put the plaque, I've made sure that I have taken the inferior rectus component also along with it. It does not alter the depth at all, the thickness in the inferior rectus area, but if we compromise on the inferior rectus component, then we will be overdosing the rest of it. So what we do is, we just make sure that an edge of it is lying onto the inferior rectus, and we were able to cover it. The size of this plaque was 24 by 21 mm, and the lesion size was approximately 20 mm. So we have to keep a skirt of 2 mm on either side, so we were able to cover it with the 24 mm plaque. Yes, sir. Before the planning of plaque. Yes, sir. So as the biopsy of the lesion, so it's a contraindication. Any of the surface lesions where we are suspecting an OSSN or a melanoma, a lot of people don't know this, but even on eyelid tumors and conjunctival tumors, a small biopsy or an incision biopsy is actually a contraindication, because we leave a focus for its spread. The moment we touch these lesions, we actually follow the no-touch technique. In the no-touch technique, what we do is, we do 4 mm clinically clear margins. We don't even touch the tumor. We go around the lesion and we take it out completely. We try not to breach the capsule at all. But the plaque is with us. We have 2 plaques. We have one notch plaque, we have a round plaque. That is already with us in the safety. Yes, sir. Not an ocular surface lesion, sir. If it's an invasive type only, sir. Correct, sir. Absolutely right. The aim of plaque brachytherapy is moreover to make sure that there is no recurrence. We are not treating a systemic aspect with the plaque brachytherapy. Plaque brachytherapy is making sure that we don't have a recurrence, because if we have a recurrence, we are already anticipating higher rate of metastasis.
How we are going to take care of the regional mets?
So we analyze it with PET CT first. If on PET CT it confirms that there is a regional metastasis, we keep the patient on either chemotherapy or immunotherapy.
The PET will not pick up your occult mets.
Agreed, sir. So we do repeat PETs every year. If at all there's an occult metastasis, I always inform the patient that micrometastasis is always a component, because we cannot catch it less than 2 mm.
Okay. So suppose if the other eye was normal, we would have done the same treatment planning?
Other eye is normal still. You mean to say if there was nothing on it? Yes, sir. The planning would be the same.
Okay.
In fact, as I said, we have an advantage. The advantage is that she's already pseudophakic, that she's had a cataract surgery already.
Yeah, I'm saying the opposite eye, if it was normal and if this was squamous cell carcinoma,
I would do the same.
plan would be the same.
Yes, sir.
Okay.
So before I go further, I will just take a small moment and thank the team of Radiation Oncology for being there like a rock. And also they were there inside the OR along with us for the first case. And I'm really happy that we were able to carry it forward along with our residents as well. So thank you for everyone for being there. And this is exactly a glimpse of my previous place where I was operating. This is in fact the first plaque that we placed, the Indian made plaque, where this is how the plaque is placed, and I just wanted to give you a glimpse of how it is done and how it is sutured onto the sclera for a given duration. And it's my mentor, and I would like to thank him for introducing the Indian plaque. So we went from this presentation to this, and that is what is the biggest achievement for us, because this patient was one-eyed. Her vision was 6/12, and we are able to retain that. It's an important aspect, and we should keep in mind that the necessity part always comes with like how the vision salvage, the eye salvage, and life salvage, and we were able to achieve all three for her. We did proceed with a PET CT scan. If Dr. Tarun Jain sir is here. Right. Thank you, sir. So I would request Arun Jain sir, who has extended his support from nuclear medicine, to please help us out with his findings on PET CT scan.
Thank you, Dr. Rolika, and I am Dr. Tarun Jain, and I am showing you some PET CT images after the treating the case. And in this image, arrow. Yes. In this case, you can actually appreciate by the front scene, you can seeing that there is no anterior chamber in the left eye, so it's look like a pathological, but there is this disease eye which is operated in the beginning of her life, and we are facing the pathology, and we have treated the pathology in the right eye. You can actually appreciate there is a lens in the left eye, and there is a preserved anterior chamber as well as the posterior chamber. In the orbit, there is nothing inside the orbit, and there is empty, and there is nothing in the posterior as well as in the anterior chamber. And you can remove the images. How we appreciate the thickening, and we have make a angle in the between the lamina papyracea and the medial rectus muscle. You can, this is the lamina papyracea and this is the medial rectus muscle. This angle should be less than 10 degree. When we are going for reporting in the any pathology in the medial canthus, we found this, in this case we found the angle is more than 20 degrees. So something was there in the medial canthus, but in the PET images there is nothing in the PET CT images, so there is no active pathology in the medial canthus. In the whole body images, we did not find any lymph node in the preauricular and submental and submandibular region, so there is no metastatic disease in the present case. Thank you.
Thank you so much, sir. I think the rest of the slides did not show up, but thank you, sir, for sharing your thoughts on the PET CT. So we have already deciphered that there is no systemic metastasis, and this is post-operative PET CT, so it has been cleared that there is no more SUV uptake in the region. That means we have been successful in treating the lesion completely. So this is how we went from pre-op, and this is post-operative 4 weeks. The whitish component that you see, that is an amniotic membrane graft that we put to reconstruct the surface, and that will keep dissolving. The patient is scheduled for a follow-up in the coming week. That will be her 6-week follow-up. And this is some pictures from my previous workplace where I just wanted to show you how the long-term follow-up works. This is a follow-up of 10 years on an OSSN, and this is a follow-up of 12 years on a recurrent melanoma.
What are chances of vision loss in post long-term consequences?
Because of plaque brachytherapy, sir? So because of plaque brachytherapy as such, the vision loss chances would be only 2 to 3%, but that will also be because of either cataract or radiation retinopathy. If we are looking for cataract, we can always do a cataract surgery and salvage it, so functional vision loss will be very less. But if we have cases where radiation retinopathy occurs, we always have to worry about that aspect. So what we do is, when we have intraocular lesions, that means that we are going near the retina and the macular region, then in that case we give prophylactic and intravitreal injections. So we give anti-VEGF injections, 4 injections, which protects the eyes from radiation retinopathy, and that reduces the vision loss issues.
So, Rolika, if you radiate implanted lens, means plastic lens, does the local radiation damage the plastic lens?
No, sir.
No effect on
No
that.
effect on it. Even the zonules.
Do you regularly do OCTs
Yes.
on the follow-ups?
Yes, sir.
To see whether any radiation
Yes,
effects
sir.
are there on the retina or not?
Always, sir.
Always.
Yes, sir. So this is just a review of literature which I have been able to gather with how there were different types of plaques that were used. Iodine, ruthenium, strontium were being utilized, and they did follow the same concept that there is scleral or corneal or base involvement, and in those cases there have been cases where they required enucleation and exenteration still, but there was no local recurrence. That means that in the cases where it is radiated, there is no recurrence, but beyond that radiation area, recurrence can occur. And we performed a study in 2024 that we finished, where there's a large sample size where scleral and corneal base involvement. This is the one which is already under publication from my previous workplace. So this is what I would say the essence would be. We take the multimodal management, and the benefit of us being over here is that we're able to utilize a lot of departments coming together for one patient. And that is the whole point that we are here and we have gathered together. So what we do is, the ocular oncologist does 4 mm clinically clear margins based on the analysis which has been gathered from radiation, from radiodiagnosis, from ASOCT UBM, clinical examination. We proceed with lamellar sclerectomy if required. We do alcohol keratoepithelectomy for the corneal component, as I did done in my patient as well. And we do double freeze-thaw cryotherapy to the edge and to the base. Cryo has known to cause disruption of the malignant cells in the local area. And we do adjuvant plaque brachytherapy, and we do histopathological confirmation no matter what. So keeping these things in mind, for ocular surface lesions, we have been able to get a life eye and vision salvage of 100% and 80%. Now, vision salvage over here is not just dependent on plaque brachytherapy, it also depends on the extent of the lesion. We have received patients where the lesion is all over the cornea, and that makes it slightly difficult. And also we have utilized it, as I showed you this example of a patient where there was a choroidal and iris melanoma with a hyphema, and it resolved like this. So it's really important that we don't enucleate these eyes anymore. And we have been able to identify that plaque brachytherapy, that is the indigenous one, is actually equal to the imported plaque, and it is non-inferior with a cost reduction by 95%. So what we were able to get for lakhs of a very high amount, we are able to get to at a lesser price. So to conclude,
Brachytherapy are common for the extraocular and intraocular or not?
Yes, sir. Actually, it is not that common in India. We have been able to bring it to Rajasthan and make it common now.
This lesion was the extraocular
Surface, yes,
yes,
sir.
but suppose it is intraocular,
Yes,
in the uvula or in the melanoma like that.
Right, sir.
So same therapy
sir.
will work?
Yes, sir.
Huh?
So what we do is we go around the eye. So even we go to the level of optic nerve. So if there is a lesion which is adjacent to the optic nerve, we actually use a notched plaque. We go around the optic nerve hugging it, and we put it from outside the sclera. So the lesion actually radiates it, as Pratibha had mentioned, that there's an isodove curve which forms around it. We deliver an apex dose as per the thickness of the lesion. So what we do is we do an ultrasound, we do a B-scan analysis, we assess what is the thickness. Now, the limitation that we have with ruthenium is that it is good with, it causes less toxicity, but the thickness it delivers to is approximately 6 to 7 mm. Iodine, on the other hand, can deliver to 8 to 9 mm also. But I prefer ruthenium, and for a larger lesion than that, we prefer to enucleate.
So the message is that it is useful both intraocular
Yes,
as well as extraocular malignancies
Yes,
or
sir.
tumors.
Yes, sir. Right, sir. So to conclude that the Indian-made plaque is actually as good as the imported plaque. We have excellent long-term vision iron life salvage with significant cost reduction, and this actually increases its availability to the society, and it is absolutely made in India. So we are actually adding to the PM initiative, and we've been able to treat all the following diseases. So I thank all our patients, our residents, and all the dignitaries who have been able to contribute to this. And the most important slide is not this one, but actually is this one, because in the order of the people who touched the plaque brachytherapy concept, I've put their names. I had to think a lot, because it takes a village to treat ocular cancers, and our village is growing. Thank you so much.